Good afternoon. I hope you've enjoyed your lunch. Thank you for joining us for this session entitled Contemporary TAVI, the Vision of Lifetime Management. This session is sponsored by Abbott Vascular. And the aim of this session is really to discuss the various aspects of TAVI well beyond the index procedure. What's going to be relevant for our patients with their longer term follow-up. To do this, I have my co-chair, Ole de Backer. Welcome, Ole. I have Chiara de Bas, Maurizio Taramazzo, and Danny De Veer. We are missing Gilbert Tang, unfortunately. I'm sure he'll join us. We know that he was in New York, and now that he's in Paris. And also we have a chat master, Fadi Sawaya. Fadi was in Paris, but now he's in New York because his wife decided to give birth to their first child unexpectedly. He missed it by an hour, but we've had some pictures and baby Marco looks beautiful, so congratulations to Fadi, and we're sorry he can't be here. So Maurizio, you're going to take on the duties of chat master, right? So Ole, tell us how can we have some fun or some interaction?
Yes.
That terrible.
No, I want to encourage interaction. So if there's any question, please send it on the app. We will be able to address it here, or you can also make use of the mics in the auditorium here. Yes.
So we're going to base this session around a live case that Ole has recently recorded with the new Navitor Vision device. So Ole, maybe while you're going to tell us about this patient, important to emphasize to you guys that we're here to talk about lifetime management for all valve devices. We're not going to be specific towards Navitor, but of course, as this is a sponsored session, we are going to touch on the elements that are particularly relevant to Navitor Vision. So Ole, maybe tell us a little bit about your case.
Yeah, thank you. Indeed, this is a recent case, maybe 2 weeks ago or so. And it's an interesting case, I think, to share with you. So this was a relatively young, or for European standards at least, a very young patient, 64-year-old female. You see on the right-hand side a little bit her body constitution. So she was not a tall lady, 158 centimeters, but despite this, she had a weight of almost 100 kilos. So she was a BMI of 40, roughly, known with some arterial hypertension, dyslipidemia, some pre-diabetes even. And the issue with her is that she was in February hospitalized for a long period, almost 6 weeks. She's known with chronic obstructive pulmonary disease. She had a severe exacerbation in February. It took her like 6 weeks to come out of the hospital. And she was overall, you can already picture the patient a bit, overweighted, a little bit frail after this very long recent hospitalization. They also diagnosed stenosis in that hospitalization, and then the patient on top of that also refused open heart surgery. So this patient was discussed with us and presented to us to treat with TAVI, and then that's why we asked for a CT on her to assess her eligibility for that. So on echo, first of all, she had luckily still a preserved ejection fraction, 60%. She had really high gradients, a mean gradient of 60 millimeters mercury, AVA of 0.7, only a mild AR. ECG, actually normal, PR below 200, QRS below 120. Apparently, she got an invasive coronary angiogram. That's not the standard in our center, to be honest, anymore. Maybe half of the patients do get it, the other not. But she got apparently an invasive coronary angio in a referring hospital, I think, to remember. So that was only showing diffuse mild atherosclerosis, hemoglobin of 11.3 grams per deciliter, and a normal renal function. If we look then to the CT, not the best quality CT, I would say, but acceptable enough for sure for analysis, for self-expanding technology. I think this can be a little bit more forgiving there. But anyway, we had some tracing here of the perimeter of 76.8 millimeter, so perimeter-derived mean of 24.5. Deeper down in the LVOT at 3 millimeter, we see similar, perimeter of 78.2, so 24.9 perimeter-derived mean, and also a little bit of calcium there at the LVOT. Then in the sinuses are measuring between 27 and 31 millimeter. ST junction, the height of the ST junction was 19 millimeter, and it was in line with the expectations. If we look to the annulus, it's not a widened aorta, so it's in line with the expectations of around 27, 28 millimeter. Then if we looked here, it's not terribly calcified, I would say, not severely, but it's definitely moderately calcified. And there's also an aspect of these black. It's not only white calcium, but there's also blackness. So it's probably, as we more often see in females, that is a combination of calcified and also fibrotic aortic stenosis. Another challenge with this lady was that her right coronary artery was at a proper height, 14.5. It looks also like a very small right coronary here, but the left main was on a relatively low height, 8.1 only. Then if we look to her aortic root, we have to look to the tricuspid view to really assess the horizontality of the aorta. That's the view to judge this or assess this on. And you see, it was, in a way, it doesn't look on the first glimpse to be a challenging aorta, or the aorta in itself is not very horizontal, but the annulus on itself is in a way pretty vertical. Yes, it's around 65 degrees. So it's kind of a hockey stick shape of the aorta, which could make it a tiny bit more challenging. Luckily, the views were in nice, reachable distance of REO 18, 20, caudal 28 for your C arm, and then the tricuspid planar is almost in an AP, so pretty good views. Here to give you also the aspect to let you show it's a younger patient, bovine arch. There was no calcium there, so that's nice. But you see still nice calcium there of the leaflets. So as I said, it's a combination of calcium, moderate to severe, but also there's some fibrotic component in it. And then the axis, I don't think axis was any issue here. That's very nice dimensions, pretty straight bifurcation for a young patient, relatively low. So no issues there to expect at all. So I think I stop with this, yes. Yep.
So, Gilbert, welcome.
Thank you, sorry.
They're very upset that you were late. So Gilbert, in Europe, this is the type of patient that we agonize over. 64 years of age, this is well below our guideline threshold of 75. Ole has outlined some reasons that this patient was, well, first of all, declined surgery. In the US, is this a standard TAVI patient at this stage?
Yeah, I would say if you look at the data, it's pretty eye-opening. You know, over 50% age 65 or younger patients now getting TAVI in the United States, which is remarkable. I think, certainly there are guidelines and there are guidelines, so once the device is approved, really there's heart team treatment. So in our condition, if the patient is anatomically TAVR appropriate, meaning you don't have hostile calcification in terms of risking significant PVL, you have good lifetime management strategy, and you can, say the patient have good hemodynamics and anatomy, I think it's reasonable to treat with TAVI with the understanding that we don't know the durability in that particular patient's age group.
Yeah, interesting, and we're going to come back to that. Does this patient have a good lifetime strategy? Maurizio, a surgeon as well. In your center, is this going towards TAVI, or would you try and angle this patient towards a surgery, be it with some rehabilitation delay in terms of the procedure?
Most likely, despite age, the specific clinical subset of patients would go in the direction of TAVI, especially due to the fact that BMI is pretty much big. Annulus is not that small, but still the risk of patient-prosthesis mismatch in this specific case is, relatively high. And we have data showing that TAVI is associated with better hemodynamic rather than surgery. So I think giving the good CT anatomy with the risk of patient prosthesis mismatch, I think this patient would undergo TAVI in our center.
Okay, let's see you guys. So in my center, if I'm being honest, my surgeons are going to try and get this patient to surgery. Who else is sending this patient to surgery in their center? Okay, so maybe about an eighth of the audience, a sixth of the audience, or thereabouts. So still in Europe, I think we worry a lot about these younger patients. Let's dive into that a little bit. Chiara, in terms of the things that we need to treat younger patients, tell us about what we need to achieve with the index TAVI procedure that Ole is going to perform in this patient. What do we need to be sure that we achieve?
So Darren, thanks for this question. If I was 64 years old and I had to receive a TAVI device, I would like that this device could provide me with some short-term and we can say mid-long-term optimal outcomes in which term exactly. When I look at my TAVI procedure, I finish, I put the device. What I want to see is no major paravalvular leaks and no AV block. So in order to do that, I need to perform a perfect implantation. So my device should be able to be implanted in a controlled way. Why? Because I could obtain in this way perfect depth. So on one side I have good sealing, on the other one I don't have the need for pacemaker. But at the same time, this delivery should be supportive to control, but even minimally invasive in terms of respect of possible complexity of the iliofemoral axis. Why that? Because I'm young, so I can have probably tortuosity more than calcium, but why not calcium? We saw it in the valve. So I would like to minimize my vascular injury and vascular complication, because we know that often it's simple to put the device inside, and then the only complication you have is peripheral, and now you are just losing the effect of your TAVI. But looking at the mid-long-term outcome that I would like to have is a remarkable hemodynamics. Why that? In terms of gradient and orifice area. We are treating aortic stenosis, so if I want to relieve patient symptoms and, of course, to improve the quality, I need a valve that works in place of mine. So I think these are the three aspects that in the very young patient should be considered, at least in the index procedure.
Okay, so Danny, no PVL, good access, single-digit hemodynamics, big EOA. What else is important during the index? One of the things that comes to mind for me is the ease of procedure.
Ease of use.
Ease of use. I mean, are self-expanding devices, do they continue to be more difficult to implant than balloon expandable devices? Is that relevant to the index procedure?
Obviously, it's very relevant, especially when ease of use is translated in some way to cath lab efficiency, to the length of the procedure, to our ability to do these procedures quickly and safely, and also to the result, to the end result. Ease of use may lead to, even it's not easy, to malpositioning, to several repositioning, and obviously these are associated with worse outcomes.
Okay. Ole, a good question for you in terms of hemodynamics. We've seen over the last decade a number of studies that have looked at gradients post-TAVI. And we've seen fairly similar gradients at cath when the TAVI's done. And then we see differences in terms of the echo gradients afterwards. Mm-hmm. Can you tell us first why that happens? And second, which is the important gradient? What determines structural valve deterioration in the longer term?
Yeah, there's all kind of theories about pressure recovery, etc. But I mean, invasively, you always typically underestimate your true gradient, I think. So we always let us guide by the echocardiographic measured gradients, to be honest. And look, I mean, there has also been a lot of discussion about what does give you the best hemodynamics. Is it really the supraannular leaflet position, yes or no? I think we really have to step away from that idea that it's the supraannular leaflet position that gives you the better hemodynamics for your valve. I think it's more than that, and it's maybe other aspects more than the leaflet position.
Such as? Tell me what other things apart from whether the leaflets are high or low?
Yeah. Well, it's indeed more how much this in the systole, how much these leaflets really do open. Yes, and if you look to this particular, you still see the Navitor here on the screen. These leaflets, they can open up all the way to the end, to the side, to the stent frame actually. And why is this? Because if you're working with a short stent frame, where you need some sutures to hold these leaflets. So if you have a short stent frame, you need to incorporate these sutures, which take some space, into that opening area. The beauty about this valve is that you have a tall stent frame, so you can see actually that these commissures where the leaves are sutured, they're hanging actually above it, and they are kept out of the opening area, and that's why these leaflets also have they are designed to open completely to the side. So your opening areas are actually on par with valves with supraannular leaflet position.
Okay, so what you're saying is that despite the fact that this is an intraannular device and leaflets, and therefore can be constrained, because the leaflets go all the way to the frame, you get a better opening than other interannular devices where the leaflets actually don't go all the way to the frame. Okay. Danny, this lady's 64. She's got multiple risk factors for coronary artery disease, and Ole told us from the angiogram she doesn't have coronary disease, but she's got 2 decades to develop coronary disease.
For sure.
Tell us about coronary access and how important that is in terms of designing or deciding on what device to use for this lady.
Obviously, we cannot dismiss the coronary arteries. The aortic valve is so nearby. We are so close to the orifice of the coronaries. And it's a spectrum, right? In one side of the spectrum, it's the high-risk conditions for acute coronary obstruction, which is a life-threatening complication that we need to identify and prevent by all means. On the other side of the spectrum is the need for post-TAVI PCI. And the need for post-TAVI PCI on that lady, although she doesn't have a coronary disease that is significant at the moment, is quite high because she does have risk factors, and we do expect her to live a decade or 2 decades or maybe more than 2 decades. So we need to enable good coronary access for potential procedure for that lady. And there are many characteristics that will enable good support for doing a coronary angiography and PCI. Some of these characteristics are related to the patient. Some of them are related to which actually she is at high risk, right? She has left main height of 8 millimeter and a bit of effaced sinuses. So she is in these criteria at somewhat higher risk for post-TAVI coronary intervention. THV design, obviously, we would prefer to have good commissural alignment in her case and to have large cells that potentially will enable good access to the coronary ostia. And in this case, choosing Navitor would be the right thing to do. And obviously, there are implantation or operator-related characteristics related to the procedure itself and related to what we want to do in the future.
Okay, so let's talk about cell size. We see 21 French in the slide there, right? Navitor.
Did you do PCI with the 21 French at some point?
Well, but not our usual practice, let's say. But we know that Navitor goes between 14.6 and 22.6, depending on the valve size, right? So there are different cells according to the size of the valve. The bigger the valve, the bigger the cells. But ultimately, big cells. The second issue is commissural alignment. We can get reasonable commissural alignment, but not every case with Navitor, right? But from what I hear, it's coming. Do we know it's the next 12 months, 18 months it's coming? We're going to put that out to the Navitor people in the audience.
Well,
12
look,
to
what
18
you can
months,
say
guys.
is we didn't maybe fully crack the code yet how to do it, but it's maybe time to go deep dive into it and try to crack the code how to do it technically, because now we can do it because these markers that come in the Navitor
We can see.
We can see. So I think we have to give it a new try and think of a new methodology, and I think we will be able to do it.
Yeah, I agree. I don't see why we wouldn't be able to, because we can see what we need to achieve. We just have to make the system do it. Okay, so in terms of coronary access, big cells, low leaflets, and commissural alignment to come. Okay. Gilbert, tell us then about structural valve deterioration. What do we know about structural valve deterioration in general in terms of average durability of TAVI valves versus surgical valves? And then give me some specifics in terms of Navitor. How is Navitor doing in this respect?
Well, that's a great question because most of us in the podium focus on the two valves that have been in the market longer, right? So there's the Sapien. You can see actually on the top left, actually this is from the Vancouver group, was probably tracked the most longest longevity of balloon expandable valves ever. Starting from Cribier Edwards valve and the Sapien first generation valve, and they shown that of those patients who actually survived have a pretty good durability. And of course we know on the bottom left, of the partner 5-year data, right, with low-risk patients, average age 70 in the 70s. They also have pretty good in terms of durability from the standpoint of aortic valve reintervention, relatively low compared to surgery. And of course, we have the Evolut 4-year data as well on the top right panel, showing excellent, in terms of hemodynamics and also durability versus SAVR in terms of severe structural valve deterioration. But we actually have a number of presentations on the 5-year data on the portical valve. Obviously, we don't have 5-year data on the Navitor because it's relatively new. But you can see actually the percentage of prosthetic valve failure of 3% is very much over 1,600 patients, very in keeping of the other transcatheter valves out there. And if you look at valve reintervention, 1.8%, structural valve degeneration severe of 0. And you can see this is also including small annuli or large annuli. So despite being intraannular in design, but the valve leaflets are tall, as Danny mentioned, this valve stands shoulder to shoulder to the other existing platform. So I think it's very important for us as TAVI operator to look at all the device out there, not just obviously 2 market leaders that we know of who's been existing long term, but also some of the other ones who actually have had at least 5-year data. We don't have 10-year data yet, but certainly this is important to make a note.
Okay, bottom line, this seems to be equivalent to all of the other devices, and with the good hemodynamics that we see may indeed surpass some of these devices, right? Because any tissue engineer worth their salt are going to tell you that the thing that determines valve durability or leaflet tissue durability is gradient, it's turbulence. And if we've got an intraannular stent frame, but good opening area, we should do okay. Mauricio, how does this compare to surgical data? Because we constantly hear this thing that, well, we know how long surgical valves last. We're not too sure about how long TAVI valves last. I mean, the first randomized trial that looked at core lab adjudicated surgical valves and TAVI valves was PARTNER, right? There was never a core lab adjudicated surgical valve that was followed for 10 or 15 years. So tell us about your understanding of surgical valve durability.
Yeah, actually, this is true. Most of the long-term data on surgical valve durability are based on reoperation. So there are no actually core lab adjudicated gradient, and there are no precise definition of structural valve deterioration, which are now be able to define in a uniform way. So there is a lot of confusion. It is probably true. It is actually true. It's a clinical observation that surgical valve has a great durability if properly implanted. So if we avoid patient prosthesis mismatch, if we avoid some specific type of valve, some valve have been recently retrieved from clinical use, but of course there are many patients that are still with this valve implanted. So, but generally speaking, some specific valve like pericardial valve, bovine valve, they have good durability, but I don't think we can actually say that they compare better in favor of TAVI. We don't have this data. It is eventually probably true, but we need data to prove this. And obviously, if we perform a proper index procedure and we select the proper device in our TAVI patient, we can actually move this comparison in favor of TAVI eventually. So it's obviously depending also on which valve we implant also in TAVI patient.
Agreed. And again, if you guys have questions, if you have a comment, if you want to throw it at the audience or challenge what any of us are saying, please do so. What about them? The other thing that we've learned from surgery is the importance of prosthesis patient mismatch. Is that relevant in TAVI? How often do we see it? And particularly with an intraannular self-expanding valve, how common is it?
Yeah, it is definitely a relevant clinical issue. We know that patient prosthesis mismatch, especially if it is of severe degree, does have an impact on symptoms release, on mortality, and also on durability. So it is something that we should absolutely try to avoid. Probably for many years in TAVI, we were mostly paying attention to paravalvular leak and arrhythmia disturbances, so conduction disturbances. Now we are focusing over the last few years that also gradient hemodynamic is especially important in younger patients like this one. And in this specific case, when the BMI is more than 30, I think the risk of patient prosthesis mismatch of severe degrees is really high. So we really should select a valve which combines the advantages of a good hemodynamic but being intraannular. So we can have easy coronary access, good hemodynamic, and easy TAVI in TAVI eventually in the future and better durability. And
Ole, any comments from the audience? Or?
Yes. So one question is age in this patient a realistic way of anticipating her life expectancy? She's 64, but with defiantly higher physiological age.
Okay, Chiara, why don't you take that one? Ole, you're not allowed to take it because we know you treated the patient. So.
Well, maybe she is 64 and she will lose some weight. We can know that, so she will improve her physiological age even. So I would say that indeed I would expect for this lady at least 20 years beyond. So I would say that probably I should really insist on the best device today, because I have to guarantee the longer and longer we can see even patients living more today, because we are improving that. So I would really consider long life expectancy for this, and I would improve our symptoms indeed.
Any others, Ole, from the audience? Or?
No, well, I want to add maybe to this. I mean, I know the patient, of course, and this was really a patient with some pre-diabetes, such a real diabetes profile, you know. I was even surprised not to see her on any diabetic medication. So regardless to that, I think she had her overweight, she had her severe COPD, which often exacerbations. It's questionable if this lady if these are the patients who have still 20, 25 years in front of them. I do not know. It could be, hopefully for her, I would say, and hopefully she does, but it's very unlikely. But another question was here, and that's more about a technical question: why not a balloon expandable valve technology? So maybe some other
Gilbert.
Gilbert.
Yeah, I mean, so first of all, I think we need to be mindful that we always say, do what's the safest for the patient, right? Okay, so obviously this is an avatar session, but do what's safest for the patient. They can get out alive and go home and enjoy time with their family. So now, assuming you can do that, that's pretty low bar, then you need to think about what can be the best result out of the patient. We'll talk about that in a moment in terms about how do you optimize the index TAVR valve for the patient. And it's not just a valve choice, because if you look at the hemodynamics, you can see that here into the gradients, that we know that all balloon expandable valve, because intra-annular design, the short frame, typically it's rare to have low single-digit gradients. Doesn't matter how many echoes you've done. Maybe invasive hemodynamics you can, but now we have an alternative that is, at least in our hands, easy to use. In terms of a self-expanding platform, have single-digit gradient, and this is pretty consistent. At least up to our 30-day data, there's no change at all, and has not really increased the next day in discharge, because sometimes the cardiologists call you, hey, how come the gradient now is higher at their clinic follow-up? So in my mind, I think yes, you can use a balloon expandable in this particular anatomy, but I think if there's a better choice out there for this particular patient, I would go with that any day.
Yeah, and maybe just to reiterate that, I think the real advantage of balloon expandable is short. So if you can keep it underneath the coronaries, then a valve-and-valve option is perfect afterwards, and she's got great coronary access. But with a left main of, well, not always, but most of the time, right? But with a left main of 8, you can't keep it underneath. So the real advantage of a balloon expandable valve in this particular patient maybe isn't there for me.
No, you could even argue that there is maybe a slight risk of coronary occlusion. Yes, I mean it's so. But there's two questions about linked with each other about the interested in the TAV in TAV, the redo. If you end up in a redo scenario, or
yeah. So I'm gonna skip over those questions, but I promise you we'll come back to them, because once we've seen the case and we've seen the result, then we're going to come back and talk about that. Danny, one thing we haven't touched on: pacemaker. Right, contemporary pacemaker rates should be under 10%. We saw with the SMART trial equivalent rates with balloon expandable and self-expandable in terms of pacemaker rates. Is that what we would expect with this patient?
This is what we should aim for, at least. It is part of lifetime management of our patients. Pacemakers are not without adverse events, not without acute adverse events, and not without long-term adverse events, especially when they can damage the tricuspid valve or to have endocarditis later on. There are issues related to pacemakers. And also, I would argue that even softer conduction defects like LBBB, they are not healthy for having our patients decades with LBBB, if we can avoid it. So obviously, conduction defects should be minimized as well.
Okay, so we're going to have a choice to make with this lady, though, right? Are we going to go deeper and give her a higher risk of pacemaker, but hopefully leave those coronaries free? Or do we go higher and hope that we develop some technologies in the future to try and cut those leaflets so she can have a TAV and
We
TAV?
will.
I know we will. Well, you're going to develop them, right? but I think that's an important consideration when we're doing the index TAVI for these patients that are particularly young. Final question for you, Gilbert, on this particular patient. She's got a BMI of 38. Is that on its own an indication not to do surgery? Because my surgeons tell me, oh, we can do a root enlargement, and they never do it. And I know we have this conversation all the time. But in our institution, root enlargement occurs in less than 1% of aortic valve surgeries. With a BMI of 38, is this lady just better going and getting any kind of TAVI device compared to a small surgical valve?
Well, we know for sure that a supraannular self-expanding device does better, right, with TAVI than surgery. That's been shown now with in terms of, particularly now with the Evolut low-risk data. That's actually quite convincing. The problem, as you mentioned before, is that it's not just surgeons not doing root enlargement, but actually they are downsizing and cinching the annulus down even smaller. So actually we've done some interesting study looking at what size surgical valve they put in the patient who had a CT analysis. And you'll be shocked that, the patient was sized, let's say, for a 23 millimeter balloon expandable valve, they end up getting a 21 surgical valve, or maybe even smaller, because by putting pledgets around it, they actually cinch the annulus. So which is unfortunately cause iatrogenically severe PPM. So I agree with you. I think if the patient anatomically is suitable for a TAVI and you can potentially do lifetime management, I would go with TAVI any day.
Yeah. So one of the things that we're doing in our institution, I know it's the same in many others, is that every patient who needs an aortic valve replacement gets a CT scan. And we present that at the heart team, and if the patient has a tiny aortic anatomy and they're going to get a size 21, well then the surgeon decides up front, I'm doing a root enlargement, or they send it all to the one surgeon who does root enlargement, or we come up with a different plan. Ole, what are you going to do with your patient?
Yeah, only very short, because I think everybody wants to see the case now. So procedural plan, keep it very short. Transfemoral TAVI, local anesthesia, pre-closure with ProStyle, 14 or 16 French introducer sheet, depending on the style and the preference of the operator. Pre-dilatation with a 22 millimeter balloon in this particular case. I think that's fair enough. That's more or less based around the minimum diameter of the annulus. And Navitor Vision. So you will see here a Navitor Vision, the newest iteration on it, the 27 millimeter. And then, as what we discussed, the official instructions for use is an implant depth target of 3 to 5 millimeter. I think here with this patient with a low coronary, we aimed kind of more or less to a more 5 millimeter depth. So let's see the case. I hope this is the vision. So with these markers, which are at the commissural level, and they are actually attached to the fabric, yes, to the outer sealing skirt, not to the stent frame. So let's see the case.
So we're going to let this case roll. It's about 15 minutes. We're not going to interrupt. Enjoy the case, and we're going to have some questions afterwards.
Some other favorite projection that you'd begin, to cross the valve?
No, indeed. We do like in this institution to cross in the right-left cusp overlap where we are now, because as you see, you immediately understand the anatomy. You know where pictal is the non. You're overlapping the right and left, so typically it's just next to the pictal as we cross.
And if you observe the tip of the wire move in systolic jet, that usually helps too, to direct it properly.
Exactly.
So that's efficient.
That helps for us to cross. So then maybe an exchange wire. We still do like to use this step.
Yeah, some institutions would go directly with a stiff wire, no? But we usually still exchange the pigtail.
Yeah. So let's have a look. On fluoro. So that's very good. ACT is good in you maybe can turn around, Gintas, slowly.
So we are paying attention to the retainer tabs. Yes, now we see two of them.
Yeah,
they seem to be very nicely loaded. I don't see any misload. And the third one comes out there also nicely loaded. So all
and then the front is also good, the tabs and the frame. It's not distorted. Okay.
Yeah, good.
That's all good.
Good, we're happy.
Yeah, so we can keep the valve here. Now it's the moment for the stiff wire. Yeah, I'll remove this one here. Yep.
All right, so stiff wire is coming in. We can go a bit.
We can go back to that cusp overlap.
Yeah, exactly. I go there. Like this.
Okay, Gindas, you can walk it out.
So cusp overlap view, since it's very often RAO view, it also gives a nicely elongated, left ventricle. So wire positioning is typically also easier to assess from that view.
So let's get it there. I'll centralize a little bit more there. Yeah, okay, good. We continue?
Yeah, I hold the wire. You can go.
Let the wire go into the other commissure, other curvature, if you can.
Yeah. And let's be ready to pace. It will be max output, frequency 180, in a short while. The wire is not easily going to the... Oh,
now it fell. Now when they do the other commissure, which I like better.
Yeah.
Okay, good. So that's fine to me. I don't want to go too deep into the LVT unless deep. Okay, so ready for pacing, Ranu? Okay, good. So let's make this ready here. Okay, pacing on, please.
Let's see if we have a good
If we
capture.
have a good capture or not.
We have a good capture. It's a good capture. It's a fast pacing on. We
Yeah,
go up
okay,
with the
you
balloon.
go. Yeah.
Yeah.
Go.
Like.
Okay, it
almost.
slips up.
Wait. One more time.
Yeah.
That's okay. We're
Yeah,
fully
that's
up.
good.
That's good. That's nice.
Stop pacing.
Stop pacing. Check for AV block. So we're observing whether or not we should disconnect or is there a complication. We can disconnect. There's no AV block, so we disconnect.
Yeah. Okay, I'm ready. We're gonna change. I'm gonna inform the patient. Wait a second. We press lusken. All right, good.
So a said patient is in local anesthesia, no sedation. So of course these maneuvers of exchange, they are not pleasant. Despite the local anesthetic is given in the groin, patients still can feel it. And if there's no sedation, it's important to let them know what's happening. That's exactly what we try to do. We have a nurse who is dedicated to talk to the patient and to keep the patient well informed. During the case,
make it nice wet, so it's nice hydrophilic.
Exactly.
Okay, somebody holds nicely the wire.
Yeah, holding the wire on. Tell me if we need to rotate. Sometimes if there's resistance in the skin level,
it goes super nice.
It goes easily. Okay. Sometimes rotation of the system helps. Like you can.
Yeah.
But in this case, it looks like we already went fine in.
Yeah. Okay, good. We go further in. You hold the wire.
I hold the wire. Watch it.
Don't hold it too tight that we fall into the other commissure, preferably again.
Yeah, but it will go back.
I think I will stay in this view.
Yeah.
Because this valve crosses that easily the arch.
I'm railing you a little bit, so I'm pulling gently on the wire to facilitate arch crossing. And you see the valve crosses the arch pretty well.
Now it falls into the other commissure, which is good.
Exactly. And I'm
good.
I'm
I will
railing you
zoom
too.
in here. We'll go slowly. We can activate contrast also. Let's connect to the pressures also. Yeah, all right, that should be it. We have pressures. Yeah, we have. Okay, I'm putting in a good position here. Pigtail sits fine. We have these nice markers there. Maybe wire it a tiny bit further.
Yeah.
Could be nice because we came in front of the papillary muscles again, I think.
Yeah. There we go.
Now we passed them again. Yeah. All right, good. Okay, we start at 0 here. And then while opening, we will let it sink into the markers at the annulus level.
Sometimes, though, this is a very flexible system, so it
we
sometimes has a tendency.
I think we should pace a bit because everything is
we could
rocking quite a bit. Patients should also lay still and not talk at this moment. We can inform her. Yeah, that's when we have it. Maybe it's better. And then a bit more even cuddle. Yeah, like this is good. Yeah. Okay, let's pace a little, 120.
Yeah. So as you can see, we have these new addition on this valve are these 3 markers that you clearly see right now. So they help us a lot to get out of the parallax and also judge the depth. The distance, from the bottom of the marker.
So we're not fully in the bottom.
Yeah, but the distance would be it's quite okay. I kind of like it this position. The distance between the bottom of the marker and the bottom of the frame is 3 millimeters. Yes. And now I'm not pushing on the wire. Wire is relaxed. Thought I will probably pull back if necessary if the valve sinks. I don't think you should.
No.
The height is fine. I would just try to keep it as I see it. We try to stay out of the parallax. The valve is well aligned parallax-wise. It seems to be in a good depth. Maybe
we don't have full capture, I think.
Okay, let me try to see if I can move the wire a little bit. We're connected otherwise. Try to pace 140 around
140,
here.
Do 140.
We seem to have capture now. That's all right.
That's better. Yeah. Okay,
and that is fine, I would say.
160.
Gentle pullback on.
I do that now.
Yeah, like this. That's perfect. That's okay. That's okay. It's okay. It's all right.
100.
Yeah.
And there's some parallax in the valve, and Okay, let's try to take that parallax out.
So next
Probably
steps,
have to
we
go
will
more
check it
far.
from two projections. Yes, we will check it from
Yeah.
RAO caudal, something close to
We
cusp
can check
overlap.
on this one.
Yeah, let's do that. It's
It's
enabled.
almost cusp overlap.
Yeah. And this is
Quite high.
we're quite high, but let's look at the other side too, because this could be acceptable if the other side is really good, because we're kind of on the inner curve. But let's see what the other side, and the shape is nice actually. You see, you are central, Ole, and in this position,
I
it's
think the
very
left
promising.
will be fine.
Yeah. You're central in the aorta, and you're for sure, if anything, deep on the left.
Yeah, but it's indeed.
So-
it's also because it's that horizontal. It's kind of that hockey stick.
So now the question is,
aorta.
do we want to make it more horizontal, or are we happy that it stays, follows aortic path? Because
Yeah.
the valve will, of course, have to follow aortic path as we let it go. And on the non-side, we're high.
On the non-side, we're higher.
If we play back like here, we are really like 1 or 2 millimeters below the cusp on the non-side.
Yeah.
We are deeper on the left. If we want to be higher on the left,
You
we
have
can
to
do
play
that.
with the wire. Yeah.
Yeah, then I have to push on the wire a little bit. We can do that.
We can try to give it a try to be more symmetric. of
Yeah,
that,
let's try to do that. Like maybe we can demonstrate that. Then I will try to push on the wire gently.
Let's find me first an angle which is kind of nicer, where there's no parallax.
Yeah.
Maybe this. Although that LAO is maybe better to judge whether we have a lot of push on the
I
wire.
would say
Maybe
so.
I would
say so. Yeah.
try to go exceptionally sacrifice our cusp overlap here. And here we see more what we do into the arch. Yeah?
Yes, and we see our pigtail, which tells us where the outer curve is.
Yeah.
So let's be ready to pace a bit. We're pacing still, but let's pace maybe 140, because now we are recapturing the valve. We don't want that valve to... Yeah. So the patient is very stable. Systolic pressure 130, all is good. And you probably will need full recapture. If we want to make it more horizontal,
I agree.
we need
We have
full
to
recapture.
come away from that left side.
Because if you do partial recaptures, it usually becomes
agree.
more vertical.
Okay. You can try to play with the wire now.
Yeah, and now let me advance the wire. We have a little bit more push on it. Gentle. I don't do anything very aggressive, but I just keep gentle, more push on that wire so that the valve
140
is...
again?
Yeah, so we're pacing 140, I think. Yeah,
think it's
we
fine.
have a lot of extra
160?
systole, but that's okay. That's okay. Ole. That's
160, 180, this is maybe perfect.
Perfect.
Yeah.
Very good. And 100 pacing.
100 pacing. This looks better. I like it. It lays itself like more into
If you
the...
maybe hold the sheath order just in case so that it's not... We can now check also the position from two projections. We always do that. So this is now more caudal.
It's almost perfect. It's like around 5-ish.
And let's
But
go
very
more
nice.
LAO maybe. Let's even...
Or this was not at all cusp overlap. Yeah.
Yeah,
We
so
could,
let's do
or
that.
I can do the more LAO. Yeah.
Because we're interested to know how are we, in that arch and that left.
I go probably a little bit more
like
thin,
this,
like this. We want to double check still on the LAO side.
Yeah,
Huh?
yeah.
I think it's perfect.
Yeah, so it's
nice.
aligned much better.
You see even here, one of them looks even higher. So it's in that zone of 3 to 5.
Yeah. And maybe before we fully release it...
Yeah, we can still look into a more extreme than cusp overlap.
Yeah, exactly, because this
For the
will-
expansion,
for the expansion and also for the true depth in relation to the
to the non.
non-side.
You want some, normally we wouldn't give contrast here, but maybe for educational purposes we can do it.
We can do 5 cc's. It's going to be enough. Do 5 cc's, please, for us.
Yeah, you can take
Because
5.
we're only interested
In total?
in 20 per second.
That's
good.
enough.
Yeah,
Gintas, yeah.
yeah. And let's do it there. That's
All
good.
right.
Good projection. Exactly. So
Yeah, we're
so
at
we're
around 3 to 4.
yeah.
Okay, good. But then I think for the release, I think still prefer to go more, because we have here this hockey stick kind of anatomy.
Try to stop pacing around here. Let's see if we have any AV block or anything, because there was some background pacing still.
Okay,
But let's try
good.
to
So we
stop
go
pacing.
for a slow release here.
Yeah.
I'm not going to do anything spectacular
No.
here with the...
No. Wire is relaxed also. We are not pacing. Patient is not an AV block, which is also promising. You see the wire is pulled back. That lifts the nose
I
cone.
think it's enough. Yeah.
Pigtail can be left or removed. Do you have a preference for that? Like we can do both.
Yeah.
We can either leave it to check the depth afterwards, or
we can
do-
leave it. We can.
Okay, let's leave
Typically,
it.
I leave it, but yeah.
Both options are fine.
Only in very small sinus STJs, I kind of pull it back, but otherwise not really.
And you see Ollie is very slow now with release. That's important to be slow. Wire is relaxed, slow release, like that. And the valve appears to be very stable. I don't think it changed
No.
the depth at all.
No. You have to be still very careful here with the taps. It's best to take your
That's
time.
it.
Yeah.
So all three
Yes,
tabs are detached.
they're
What
detached.
what you did was rotation on the system a little
Exactly.
bit to make sure that they are detached.
Okay, just now you can slowly pull back. You can keep your wire into the
Yeah.
LV. Yeah, push your wire.
Yeah, that's what I'm doing.
Yeah, it's perfect. I think we have a very nice implant there. Now we can close.
So with the hollow one.
You can look at the hands of Quintas here. Yeah,
Yeah,
he's
so
also
I'm pulling back the
Wait.
nose cone back into the sheath, and our nurse Tanya is holding the wire for me, and now we're done.
Okay.
We're going to remove it from the body, and we will put the sheath back in.
So when you leave the pigtail, of course, when pulling back, always do it with a wire, a J-wire. We uncurl the pigtail catheter and slowly come back. Like this. And check whether it's through in 6 arrows, so that's good. It can't pull out the sheet. Yeah, now I'm out, and now I pull back on my wire. Yeah, like this. Pigtail back in place. Good. All right. This can go out. A little forward with the contrast, please. Yeah, thank you. Okay, so I think we have everything in place here. It's good to do hemodynamics now.
So let's remember,
hemodynamics is really nice, I would
our
say.
LV pressure was 22, aortic was 73 before we began the case, and now we have LV pressure 24 and 72 in the aorta, so that's very similar.
Yeah, it's very similar.
It's extremely similar, and then
That's almost exactly the same, and no gradient, zero, absolutely zero. Okay, ready for maybe 20 in total, 10 per second. Could we do that? Our nurses are extremely quick to take an ECG
so
here.
PR is completely normal, is 156, and QRS 144, so we have a left bundle branch block, which will most likely resolve, but at the moment we have a left bundle branch block, normal PR. So,
Yeah, all right.
we're happy there, that's perfect.
We'll make an injection here.
Yeah.
Very good. So that's
No
no
leak, no
leak
leak
at
at
all.
all.
And of course, you don't see the sinuses because they are not filling because they are so small. But we know from the pigtail from before, the pigtail was sitting completely into the bottom there. So
Yeah,
we have
yeah.
this kind of position. It didn't change. So we are exactly, I think, there where the sinus, the annulus really is. It's 3 actually, and then we can check on the LAO view. Also there, I think we're around that 3. You see the cusp there.
You
and
can
the-
look how the stent shape looks like. That's
Yeah.
also interesting to
Yeah.
look from LAO.
All right.
Yeah.
So really nice result, I think. Really good implant depth. Yeah, and no gradients, no PVL.
Nice cylindrical look of the valve.
Yes, yeah.
So we'll do a quick injection here just to focus on the groin. That's it.
Thank you.
Perfect.
Okay, Ole, congratulations on a great case. Well done.
Wonderful.
So let's go back to the start. Chiara, what did you want? You wanted single-digit gradient, no PVL, no vascular complications.
So all obtain everything, and indeed the fact that you could reposition the valve once you saw that indeed you had a sort of not really aligned valve in the LVOT was perfect, even because you improved the deployment of the device the second time, and the outcome, even infra-procedural, was amazing in terms of gradient and PVL.
Okay, we also spoke about the simplicity of using the system. It's a turn knob, right? There was no stress, there was no hemodynamic compromise. The leaflets are active very early in the procedure, moderate pacing.
Exactly.
Do you pace commonly in your procedures?
Yes, I do. I know you can deploy this valve without any pacing. I know that. But to be honest, if I see the patient tolerates this hemodynamically, and this patient, you saw she was completely stable. There's no anesthesia in the room. This patient, we had to really, she was very talkative. There was a nurse because she had to, it was translation. There was a translator next to her, a nurse who spoke the same language as her. She wasn't speaking Danish. So she was chatting all the time. and even while putting the valve. So that's why I said at a certain moment, like, please get it down. So you see the patients are not chatting if they're hemodynamically not good. So I think it benefits giving that short run of pacing of 5 seconds. It stabilizes everything a little bit more. And I like to, then in these 5 seconds, I try to be really precise with the valve implantation. And then I go down immediately to 180, go down and stop the pacing. For me, it works good, but maybe it's interesting to hear other
I think you're absolutely spot on that if you have a weak patient like that, you should control pace to avoid someone suddenly take a deep breath or the patient get nervous, and that you have some control that you can control as an operator. But if you're going to have a deeper sedation, like at our center, our anesthesiologists like to put them in deeper sedation, this device does not need pacing at all, actually, which is a really nice thing to have. Especially patient very low ejection fraction, they can't tolerate any degree of control pacing. The wire is there for almost illustrative purpose only. We never even touch the wire. It's almost what we call, at least in the United States, based on our experience so far, a single operator, truly a single operator procedure. And especially when we release the valve, the first operator does not even touch the catheter. The second operator bring the wire back. You can see what Ole did already. Just, you can pace or not pace on control release, and then just release the valve, and it really stays where it's supposed to be. It does not go up, does not go down, but the key is that the first operator does not really do a whole lot. I think that is the beauty of this plan.
We pace too, Danny, but again, if you guys have questions for Ole about his technique or how he deploys it, please send them forward.
There are many questions, Darren.
Oh yeah, let's go.
If you want to address them? Or
that's most important.
First, there's a particular question about the implant technique here. They're saying, I can maybe read it exactly, about the Navitor implant depth is 3 millimeter per guidance to avoid PPI. Do you prefer to take the risk of PPI to save future coronary access and future valve-in-valve?
Yeah, so maybe it's the time to discuss that, right? So,
and maybe we have to say the markers, these new markers that come in the Navitor Vision. So the bottom of the marker is 3 millimeters, so that gives us really a nice idea where 3 millimeter exactly is. It helps in depth assessment. It also helps us a lot in assessment whether there's parallax in the valve. And then the marker itself has like a width of 1.5, so the top of the marker is 4.5. So you could almost say if you land with the marker either the bottom at the annulus, touching the annulus, or just the top touching the annulus, that's the recommended zone. And to me, really, I mean, look, 3 or 5 millimeter. If we're honest to ourselves, how precise can we manage to do this? And sometimes you end up in a very asymmetrical depth. Like that's what we had in the beginning. We were at 1-2 millimeter. We were probably at 5-6 millimeters at the left. So that's why we decided to reposition. My colleague gave a little bit more push on the wire. It laid itself a bit more horizontal, and then we ended up in a nice symmetrical depth. I like that much better. So
I think, as you say, there are multiple reasons why these markers really help us in terms of depth, in terms of parallax, in terms of really understanding how deep we are in the various cusps. Danny, we wanted to have coronary access. Have we got coronary access here, do you think?
Well, it will be tough. It will be tough, not because of the device, but because of the original anatomy. As you said, it's like a hockey stick morphology. It's a quite weird morphology, right? It's not really horizontal root. It ends with an angle. And the sinuses are a bit effaced, and the left main is a bit low. It's really low, actually.
Yeah, it's really low.
And I think that we tried the best to minimize that risk, right? You tried, and the size of the space between the frame is quite large. There is no commissural alignment, unfortunately, in that case, but it is what it is. If that patient will come back, it will be tough, but not extreme. That's what I imagine. Okay.
So Gilbert, if we're looking at this patient in due course, right, and we need to understand this for all patients. TAVR explant is the fastest growing surgical procedure in the US. But it seems like surgeons are really bad at this, as in the outcomes are pretty poor. Can you tell us why that is? And can you tell us, is there a pathway to surgeons getting better at doing this procedure?
Well, first of all, I think the number of cases each surgeon done is like less than one. okay, in the United States. Even Mike Reardon sitting here is one of the world experts in this procedure. It's still difficult because, number one, there's not just isolated AVR. There are other damages that when you take out the valve, such as you can cause a VSD or you can damage the mitral valve, now becomes a double valve operation. A lot of these time, if you're not careful with, you can injure the aorta. So these are patients, the longer the implant is, the harder it gets. It's not, we're not talking about taking it out next day. Talk about a year or 3 to 5 years from now. But we're getting better. We just published a paper in JTCVS on standardizing some of the techniques. So surgeons can learn kind of like what we do as TAVI implanters, standardizing procedure, make it more reproducible. But it's going to be some time before we can get better at this operation, not just because the operation is more complex, but patients are getting sicker. They get like PVL or they get mismatch, they don't get referred, and by the time they come, they really more advanced state of their clinical operation. And you can see that here. That's to Darren's point is almost double now in terms of the late. I mean, the good thing is that we know that redo TAVI, it's at least feasible in some patients, and that's why lifetime management is so important.
Yeah, and we're going to come to that. Ole, we've got some more questions. Let's get through those rapid fire.
And maybe because we're getting to the end, this is an interesting one because it's again on the either TAVR explant or redo TAVI topic. The question is, the counterpart of hemodynamics in the index procedure would be the counterpart of the hemodynamics in the index procedure would be the ease and safety of the valve-in-valve procedure that will be needed in 10, 15 years. How to do this balance? So for him, it's like either you go for a valve that gives you the best hemodynamics now, or you go for a valve option that gives you maybe the better option for the redo TAVI. But I think that's if you think very binary in SAPIEN versus Evolut, for example. But I think that's my personal view on this. Here, maybe we gave this patient good hemodynamics. She had single digits on the echo the day after. And I think still she has one of the better options of redo TAVI in the future. So it's not or, but we can maybe do an with this platform. I don't know.
Or Maurizio, what about in these patients, for example, an index surgery? She gets surgery and then she can have whatever she wants after that, right? Is it that straightforward that surgery, for example, in this patient with narrow sinuses, a large BSA, is a TAV and SAV in this lady in 10 years' time easier than a TAV and TAV?
Well, probably from a technical standpoint, if you do a proper index surgical procedure and you put a valve which is big enough, a stented valve, from a technical standpoint, I would say that the risk of coronary occlusion may be lower, definitely lower if you do TAVR in SAVR. But as Ole said, I think the risk of coronary occlusion in TAVI is not the same for all patients. There are some patients with some specific anatomy, so narrow sinuses, low coronary, high, small STJ, where the risk is high. There are some patients where the anatomy is bigger and TAVI is not that high risk. So I think we should also take into account the anatomy of the specific patient.
Agree. Gilbert, what do we know about revalving Navitor?
So we don't obviously have a lot of experience with this so far because it's a relatively new valve, but you can see we did one recently on the right-hand fluoroscopic corner, and we actually tried doing CT simulation now to see, where you should put your first Navitor in to maximize redo TAVR feasibility. So we look at almost 2,000 patients in the process of submitting for publication, and we actually find that if you implant the valve at kind of the optimal depth, which is kind of the 3 millimeter, and you implant a SAPIEN a little bit deeper to allow leaflet overhang, so you're aiming basically the first node or first full diamond, you have the best redo TAVR feasibility. And that's not even talking about common-short alignment. That's assuming it's completely misaligned and you don't really have the option. And if you have common-short alignment, then you can implant a little deeper, that's fine too. But the bottom line is don't implant this valve high. It doesn't do you any favors. And you don't need to implant too deep either because it doesn't really do you any favor. Just do it optimally and you can implant. And this valve is very easy to implant for redo TAVI because you can see the fluoroscopically, and Ole has shown some examples of that of the older generation Portico platform.
That's a nice message, I think. Don't go too high, don't go too low, just do it properly.
And I think this is a nice example you've shown because I think in this particular patient we treated here that you saw the recording from, if we would do, indeed she would need revalving and we would do the short stent frame balloon expandable implant position as Gilbert did there, I think she will probably come away with it and we would still have, we would for sure not close the coronary.
And certainly you can protect that coronary coronary as well, and basilica is probably still an option, depending on the commissural alignment.
Yes. Yeah.
Final questions from the audience, Ole?
Yeah, plenty. I mean, there was something still about the commissural alignment, how to do it, but I think that we gave an answer. I think we still have to crack the code there. Here, any tips for femoral access to decrease the probability of vascular damage or impossibility to advance the guide?
Yeah, I think fairly straightforward steps. There's actually a session later this afternoon on vascular complications and vascular access. I think ultrasound-guided puncture, Danny, micropuncture to use, CT assessment prior, and then always have a bailout strategy ready, I think would be the message.
For the rare cases, alternative access.
Yep.
Well, I can add to that the profile is really extremely small here for this platform, and I think maybe for the future it's interesting for the audience to know too that they are coming with their 35 millimeter valve, and that even fits into their small delivery system. Yes, so that's really could be a game changer maybe, because then you can really deliver the large size valve with the 14 French kind of system.
Final questions? No?
Yeah, there's too many. I'm sorry we cannot address them all. Maybe the last one then about the durability. One of the anonymous questions is why not choose a valve with proven durability, specifically for this young patient? On the other hand, I think the data that Gilbert showed there with up to 5 years, if you look to severe structural valve deterioration, it's actually in their cohort, it's 0. It's really 0 at 5 years for Portico, so that's amazingly good, to be honest. And then I can only, so that's proven, that's published. We can share from our Copenhagen experience. We started, thanks to our colleague also Lars Sunnegaard, implanting in 15 already, I think, with Portico. We've only had limited valves to revalve, kind of 40. And as far as I know, there's only 1 or 2 of Porticos in that. So it's not that we have a tradition of implanting a lot in our center, even early days. If there would be an issue with durability, and we have definitely patients at 8 and 10 years, up to 9 years in a life, we would have seen them showing up, and that's not the case. So that's just from our own experience.
So good, from your experience, good durability, and certainly the data suggests that. So I think we'll wrap up at this point. I think in terms of take-home messages, I think we very clearly outlined what are the issues with younger patients, a perfect index procedure, and a procedure at that time that looks forward 10 years. Commissural alignment, leaflets that can be modified or revalved, good coronary access. Mauricio spoke about good hemodynamics and making sure we don't get patient prosthesis mismatch. And Gilbert talked about, I suppose, the various aspects of structural valve deterioration that we're not seeing to date with this valve, though of course it can happen with any system. We saw a live case from Ole and his team, a stress-free implant, good hemodynamics, recapture, repositioning of the valve, and an excellent outcome for his patient. And I think we briefly touched on the much wider topic of TAV and TAV, and hopefully avoiding the need for explant in the future, as that's not associated with good outcomes. So with that, I'd like to thank all of you guys. Ole, thank you for an excellent live case. Thanks to you guys for being engaging for the last hour. To Abbott for sponsoring, and to you guys for bearing with us. Enjoy the rest of your day.
It's not always like that, you know?